getting underway shortly. It's great to see so many people joining us, some old friends and new ones. Right, so it's just 1 minute past 12:30. We're going to give it a little bit longer so that we will see if some stragglers join. I know what it's like with these lunchtime seminars. People are trying to move from one thing to another and grab some lunch at the same time and join us. Okay, well, so I will begin to do some introductions and some housekeeping. So thanks once again, everybody, for joining us today. My name is Beth Filan. I am a proud member of the Yorkshire Quality Research Group, and this group has been running the Yorkshire Quality and Safety Research Seminars for many years. I'm also an Associate Professor in the School of Pharmacy and Medical Sciences at the University of Bradford, and we are also host at YQSR to the National Institute of Health Research Yorkshire and Humber Patient Safety Research Collaboration. So we are delighted today to welcome Dr. Ray Samuriwo from the University of Bradford. I'll introduce Ray's talk shortly. However, I'm just going to go through some housekeeping with everybody here today. So we ask people to keep your microphones muted during the talk, and then if you have questions that occur to you during Ray's talk, then please do put them in, those questions in the chat, and we can make sure that we ask those at the end. One important thing to mention is that we will be recording this talk, and it will be hosted on our YQSR YouTube channel. So if you haven't seen that channel, it's worth searching for it. So we do have quite an impressive back catalogue of the talks that have taken place online and have been recorded. So they're there for people to go and revisit and to watch at their own leisure. So if people aren't comfortable with the talk being recorded, just to let you know that it will be available afterwards. So if you don't want to be here while it's being recorded, then you can leave now, and then we will circulate the link for people to be able to watch it at a later date. So moving on to Ray, we're delighted to have him here today. So Ray is an Associate Professor in Adult Nursing at the University of Bradford. Ray joined the university in February 2022 from Cardiff University, and he used to work clinically for many years in intensive care and also as a clinical academic. So Ray's research is very much focused on patient safety and decision making in healthcare, and is informed by the principles and ideas from humanities and the social sciences. Ray's work focuses on creating, testing and improving theories surrounding people receiving healthcare, to making sure that they're kept safe and always receive the best possible care. So Ray's talk today is around nurses' whisper, identities in nurses' patient safety narratives of nurse, trainee, doctors' interactions, and I'm sure by the end of the session today we'll all have some great insight into this particular subject matter. And it's not something that we've focused on before, and I know that we do have some clinical research nurses and former clinicians and current clinicians in the audience for Ray's talk today. So without me going on any further, I'm going to hand over to Ray, and I'm sure, Ray, you'll do a better job of introducing yourself than I've just done.
Thank you very much, Beth. And thank you very much, everyone, for joining me. I'm delighted to be here today. So thank you very much to the Yorkshire Quality and Safety Research Group for inviting me to present my work today. So I've been to many of these seminars before, and I've always found that there's lots to learn, lots to benefit from it. And even before the session today, I think I'd learned quite a lot because I realized that my abstract, the original abstract, was quite academic. So again, I've reflected on that, so it's been quite useful to learn. So in terms of the time we're together today, I'll be taking through one particular research study that I did while I still worked in Wales, called Nurses Whisper, and focus very much on the identities that nurses adopt as they go about their work, trying to keep patients safe in clinical practice. Essentially, in plain English, it's how nurses make sense of what they do and how they work with trainee doctors to make sure that patients are safe. But before I proceed any further, as with most good things in life, none of us are an island. We work best in groups. So I undertook this project with several colleagues of mine. Two of them are still in Cardiff. One is Professor Alison Bullock, and the other is Dr. Katie Webb, but also Professor Lynn Monroe, who's from the University of Sydney. So Lynn is one of the leading figures in identity work. She's done a lot of research into identities and those sorts of aspects of medical education. My interest is a bit more in terms of patient safety. And this particular project was funded by two Welsh University health boards, Cwmtaf and the Nair Bevan. So health boards in Wales are the equivalent of integrated care boards here in England. So I'm very grateful for the support and input of my colleagues. So as Beth has said, my main interest is in patient safety and decision making. So for all of us, I think we're all aware that patient safety is a priority for everyone who works in health and social care. Keeping people safe is really important. But just a few, I guess, grounding principles or key ideas for me. So patient safety for me is a combination of things. It's both a goal, something that we want to achieve and maintain and strive to ensure that it happens all the time. But it's also about our practice, i.e. how we go about doing things in every single day. We all know that's a priority for healthcare professionals. I think it's even more important for the people receiving care, be they be patients, service users, or the public at large. And nurses are key in terms of contributing to patient safety and making sure that patients are safe. So I think it's really important to acknowledge that before we move forward. I also think that patient safety by its very nature relies on collaborative partnerships. So it's about collaborating and working partnerships with the people receiving care, service users and the public, and also the key stakeholders. So wherever we work, there will be commissioners, legislators, professional regulatory bodies. So all of those are really key players. And our objective and goal is to try and do the best that we can for patients and the public. And my own personal view, because I said patient safety is both a goal, but also a practice or something that we aspire to do. I think it's important that we all strive to meet and exceed the standards for best practice in relation to care. So this is just, I guess, a little bit of background. So in terms of patient safety, I think as long as there have been doctors and nurses walking this earth, uh, there's been a lot of literature which has highlighted team working issues. I think there's actually a book or an article called The Doctor-Nurse Game. So historically, there's been this narrative largely linked to patient safety, that there are team working issues between doctors and nurses and their disagreements about who should have what particular role. But in terms of patient safety, it's vital that for a team to work effectively and to focus on delivering care to a high standard, there has to be a collective sense of responsibility. So everyone has to be invested in trying to achieve the best possible outcomes for the patient. And that also includes the person who's receiving the care, be they the patient or the service user. Again, like I said, there have been several studies, a wide range of literature, which talks about a key issue when there are patient safety shortcomings or when things go wrong is to do with poor doctor and nurse communication, particularly with regards to patient safety. And sort of key recurring themes are lack of clarity about roles and responsibilities, lack of insight or understanding into fundamental aspects of the patient's need, or how to prioritize and treat care appropriately. So these are sort of recurring themes that when you look at patient safety incidents or near misses or rescues, there's always the underlying current of poor doctor-nurse communication. In fairness, the vast majority of literature around this issue of poor doctor-nurse communication and team working is largely linked to the acute care settings, although there's an increasing amount of evidence that this is also the case in primary care. And this cuts across all different aspects of nursing. So it's irrespective of whether you look at mental health nursing, children's nursing, or adult nursing. there's a sort of constant recurring theme around poor communication issues. So as you can see from the illustrations there, it's almost like it's a boxing match where the people are constantly arguing over who has jurisdiction to do different things. For me personally, Beth mentioned that I used to work clinically. So my interest in patient safety and in this particular aspect of research was sparked by an observation around what we called the transition. So every so often you'd have a new rotation of trainee doctors coming into practice. And at that point in time, I observed clinically that there's a greater risk in terms of patient safety. And this is something that's also reported in wider literature. So it's reported in different ways. So there are lots of colloquial terms that are used, some which are more comfortable than others. So it's been referred to as Black Wednesday, because historically that's when the new trainee doctors came to work in a particular setting. It was also called historically been called the August or July effect, because essentially that's when you'd have new trainee doctors coming into clinical practice after they had qualified. For those of an older vintage, other phrases such as killing season have been used, but probably that's a bit too strong for me. So there are these issues that patient safety and communication issues between doctors and nurses tend to come to the fore when there's a new rotation of doctors that come into clinical practice or doctors start working in a new setting. So that's when there tend to be more of these patient safety issues. And as a result of these team working stroke communication issues, this has a direct impact on patient care. So there's clear evidence that when doctors or when trainee doctors transitioning from their medical degrees and actually coming into clinical practice on a permanent basis, there are higher mortality rates, but also as trainee doctors go and work in different settings, that also results in an increase in mortality rates. So this is very much the background to why I was interested in looking into this doctor-nurse interaction through the lens of patient safety. So the vast majority of literature, to sum up this slide, highlights the fact that there are these communication tension issues, that tensions, I think, sometimes between doctors and nurses. But the biggest issue tends to be when you get a new rotation of trainee doctors coming to work in a particular setting. However, there's one particular study from 2014, which Professor Lynn Monroe led on, which gave a slightly different impression. So this was the only study that we were able to find, which gave a slightly different perspective. And it gave a very different perspective in the sense that there's clear evidence from this study that the trainee doctors or junior doctors, if you prefer, spoke about how nurses supported them in the early years of training. And a lot of this support was around dealing with the challenge of clinical practice, helping them to with their clinical reasoning and decision making, but also providing them with emotional support. So in this particular study, there was a narrative where a lot of the trainee doctors felt they found it a bit more challenging to be able to escalate concerns, if they had concerns, anxiety, or challenges, to the more senior doctors, be they registrars or consultants, but they felt more comfortable doing so with nurses because there's a particular rapport which made them feel safe and supported. So in terms of our study, we had an aim and a couple of research questions that we wanted to answer. So our aim was to try and examine how nurses portray themselves in trainee doctors in their narratives or stories about patient safety. And the research questions, which are a bit more academic in tone, were wanted to understand how nurses construct their own in trainee doctors' identities when they talk about patient safety events. And in those stories that the nurses tell about their patient safety events, in what areas of trainee doctors' practice do they intervene to make sure that their patients are safe? So before we move on to the methods and the results, I just wanted to go through the theoretical framework or way of thinking. So the title of the session today is about nurses' identities. We've also talked in the previous slide about how nurses portray themselves, how they construct their identity. So before I move on next, I just wanted to spend a bit of time about why we adopted that particular approach and why it might be of benefits to others to use this particular lens. So the sort of academic phrase for it, our way of thinking is what's called constructionism. So it's the notion that for all of us as you go about life, we construct a particular identity for ourselves, or we construct a particular narrative around ourselves with regards to what we do. And in terms of this particular study, one of the things that we were looking at very closely is how, when we talk about things, when people talk about things that they've experienced, in this instance, specifically around patient safety, how nurses spoke about patient safety, how they position themselves and trainee doctors. And that's really important in this sense, in that when we make sense of what has happened to us, what we know, how we grow and develop, we often position ourselves relative to other people. So there's a very simple metaphor that lots of people may have come across, which is you find out who you are when you listen to what you have to say. So that sort of way of thinking is part of the research paradigm called constructionism, but also the added nuance that we use in this particular study is something called positioning. So paying particular attention to how the nurses position themselves relative to the trainee doctors within their narratives. In the previous slide, when I talked about the second research question, that focused very much on when the nurses intervene and what particular aspects they intervened when they felt that there were shortcomings in the trainee doctor's competence. So in terms of that level of analysis, we used Cheetham and Chiver's professional competence model, because that provided us with quite a useful framework to be able to map the sort of instances in which the nurses intervened, but also where they felt that there were deficits in the trainee doctor's competence and how they felt that that might impact on patient safety. And when it comes to the results, I'll try and highlight those nuances about how the nurses position themselves relative to the trainee doctors, but also how the narratives relate to particular instances of competence. And hopefully when we get towards the end of the talk, I'll all link it together as it sort of progress. So in terms of a theoretical framework, like I said, we're using a social constructionist approach. We were also informed by the principles of positioning, and we also used Cheetham and Chiver's model of professional competence, because it provides us with a very useful framework for being able to understand and make sense of what the nurses were saying. So in terms of the study, it was a qualitative study. So I undertook 20 semi-structured individual interviews with nurses from 6 different hospitals across Wales. They worked at a variety of different levels. So they ranged from very senior nurses working on the wards. We also had some specialist nurses. We also had advanced nurse practitioners, and we also had some nurse consultants. So quite a diverse range of participants, all of whom had direct experience of working with trainee doctors in clinical practice. The other thing to emphasize is, if you aren't familiar with Wales, Wales is a very sparsely populated country. So these hospitals are across a wide range of geographical settings. Even though they are within 2 university health boards, they're across a very wide geographical setting as well. So in terms of analysis, we essentially undertook conventional approaches that are used in qualitative research. So I recorded what the participants said on a digital audio recorder. They were transcribed word for word. They were anonymized. We analyzed the transcripts using NVivo. We then used thematic framework analysis using a combination of Cheetham and Chiver's model, but also used an inductive approach very much founded in the principles of constructionism. So this notion that people construct their own understanding of their experiences and what's happened to them, but also the notion that they position themselves relative to other people. So in terms of our results, what we found was that nurses essentially stated that they adopted 7 different identities. And what was quite interesting for me was all of these 7 identities basically fell into 2 broad categories. So in terms of what the nurses spoke about, the patient safety incidents and their interactions with trainee doctors, they're very much around the idea of nurses as being educators. So nurses educating trainee doctors in some aspect of medical practice to make sure that patients were kept safe, but also their role as practitioners. So these were the 7 main identities that the nurses said they had to adopt at various points in their interactions with trainee doctors. So they sometimes intervened and they adopted the role of a teacher. Sometimes they functioned as an expert advisor. On other occasions, they were navigator, supporting the trainee doctors to better understand what they needed to do to make sure that the patient was kept safe. On other occasions, they provided general support as and when needed to trainee doctors. But the main role, I think, which tied it together, is the nurses felt very much that they were the custodian or guardian of patient well-being, and it was their primary role in clinical practice was to try and make sure that patients were kept safe at all times. They also, interestingly enough, provided emotional support, which very much echoed the earlier study by Lynn Monroe. And they also described themselves as being a team player, which is very interesting, bearing in mind that the literature, or the bulk of the literature within this area, always reports tensions between doctors and nurses as being a contributing factor that can undermine patient safety. So in terms of nurses as a teacher, so there are lots of different examples that they gave us, but I've just given you a couple here. So essentially, in adopting these roles, nurses describe themselves as educating trainee doctors, providing them with information and explaining specific actions and processes. Sometimes this was informal on the ward, and on other occasions, this was a little bit more formal. So there are a couple of examples there. And the first sort of text there in square brackets indicates how they're positioning the doctor relative to themselves. So in both of these quotations, they were positioning the doctor, or they're describing the doctor as someone who was willing to learn, who was willing to listen. And for example, in the first quotation there, they're saying that the doctors would ring to them and say, can you come and support me? I've got someone, I'm not quite sure what's going on with this particular patient. And the nurse would then go and assist them. So in this case, the nurse Brenda, she's an advanced nurse practitioner. And again, for those who don't come from a nursing background, some of the advanced nursing practitioners can do many of the roles and tasks that a trainee doctor can do, such as clerking a patient, assessing a patient, and planning treatment. Some of them are even able to prescribe as well. So again, this is quite a good example of nurses functioning essentially as a teacher, being a source of support for the trainee doctors where there's uncertainty or doubt. They intervene directly. So in this case, it was to do with a blood clot or a pulmonary embolism, where there was the trainee doctor was concerned that this patient might have a blood clot within their lungs. And essentially, it's quite interesting, the last line in that quotation where Brenda says their role is basically jollying them along and supporting them in the right direction. So very practical support around making the right decision in terms of the patient's treatment as well. Then the second example is perhaps a bit more formal, where they're doing training away from the ward, and they're delivering training specifically to trainee doctors. But also there's the prospect there of being available to provide training on the ward as well. So the text that I've highlighted there in red is to do with specific aspects of doctors' competence. So in terms of Cheetham and Chiver's model professional competence, there are four main domains. So one of them is about cognitive and functional competence. So essentially, knowing how to do your job and knowing how to carry out the procedures correctly. So again, this is why we use three different ways of analyzing the data to try and bring that additional nuance and insight into this particular role that nurses play. So this was one of the key roles, nurses as teachers of trainee doctors in clinical practice, who are acting to try and address what they see as being deficits in the trainee doctor's cognitive and functional competence, and working with the trainee doctor to try and make sure that the patients are kept safe in practice. The second one related to nurses functioning as a teacher was as an expert advisor. And this is essentially where they functioned to provide advice to doctors when the doctors asked specifically for guidance in relation to some aspect of patient care. So in this instance, there are two examples, one from Pamela as a consultant nurse, and the other from Claire as a staff nurse on the ward. And both of these quotations were to do with providing advice. The first one about referring a patient. So the doctor sought advice from a nurse about what do I need to do to refer this patient. I think they need extra expert input with regards to a cardiological issue, something to do with their heart. And therefore, the consultant nurse was more than happy to intervene and support the trainee doctor. And in terms of specific domains of medical competence, we mapped that in terms of cognitive competence. So knowing what to do and knowing what the right thing is to do in a particular sort of context. And sort of similarly with Claire, very much perhaps in terms of interest, very much in Beth's domain. So this was about prescribing drugs and making sure that the medication was prescribed correctly. And Claire was saying very much, as a nurse, part of my role is to be there to support a doctor and to give them advice when they're prescribing drugs, to make sure that they're prescribing the correct dose of drug to that particular patient that they're looking after. So again, this was very much the second role, nurses functioning as an expert advisor, but also it falls in the broader category of nurses functioning as educators and supporting trainee doctors with their education and understanding, I guess, of different aspects of medical practice. Then the third one, which is related to nurses educators, was around Navigator. And again, I think this ties in more to the point I was making, that this is a key identity that nurses seem to adopt when the trainee doctors are new to that particular setting, or if it's their first time coming into practice. And again, in square brackets, you can see how they position the trainee doctors. So they're positioning the trainee doctors in their narrative about patient safety as being lost, as being uncertain about what to do in terms of their role and what they needed to do to keep the patient safe. So in the first example, Esther, they was talking about specifically giving them guidance about where they needed to find the equipment that they needed to be able to take bloods from the patient, which again is a key part of patient safety, being able to carry out diagnostic tests in a timely manner. And also, it's the second example from Barry indicates a sort of similar theme, is guiding the doctors about what they need to do in terms of basic treatment, basic assessment, but also where to find the equipment that they need. And again, it's very interesting, the last sentence in Valerie's quotation there, which also talks about the fact that it's particularly with newer doctors, but also occasionally some of the more senior doctors tend to defer to the nurses. They'll ask nurses about the key policies and procedures, because there are variations in policies and procedures across different settings. And we felt that this was very much about personal capability as well. So the ability of the trainee doctors to be able to acknowledge and recognize deficits in their own competence, or things that they're not sure of or not certain of, and then be able to ask for help from the nurses, and the nurses being there to support the doctors in that regard. So again, very interesting and very important as well. In terms of providing general support, this was when the nurses described themselves as basically taking an interest in the trainee doctors, supporting them as individuals and supporting them as people, and providing them informal help and practical support. And again, this is reflective, I guess, of the diversity of roles that nurses play. So the first quote there from Wallace, who was an advanced nurse practitioner, talks about interacting with the trainee doctors in a more social sense. So perhaps away from the patient, but in the doctor's mess, and identifying and talking through particular challenges that they have or issues that they were facing. And this was very interesting because I didn't include the codes here, but a lot of nurses talked about the fact that trainee doctors often confided in them lots of personal issues with regards to their sexuality, relationship issues, which they felt they were more able to share with nurses and were less comfortable sharing with more senior doctors. However, nonetheless, the ability of nurses to provide general support within these narratives seemed to be quite a key factor in terms of ensuring that the doctors were safe, in terms of their own psychological safety, but also in terms of how they then worked with others in the healthcare, in the interprofessional team or multidisciplinary team, to then be able to deliver patient care. And it's also reiterated, I think, in the last two quotes there from Sophie and Tracy as well, that it's about being there for doctors and being an additional source of support for the trainee doctors as well. And I felt that this was very much around personal and functional capability. So again, you can see the position trainee doctors as being people that needed nurturing. And as I've sort of alluded to, it was interesting for me that the trainee doctors tended to, or were said to turn to nurses for nurturing and support, and they felt less comfortable seeking that level of support from their more senior medical colleagues. So in terms of guardian of patient well-being, this was sort of the overarching theme within all the nurses' narratives. And you see from the first quote there, hence the title of today's talk and the title of the paper, that nurses felt very much that part of their role was to support the doctors by making sure that they kept the patient safe. So for example, if a doctor was about to prescribe a drug and they had overlooked an allergy that the patient had, the nurse would very quietly whisper in the doctor's ear that, no, actually, that patient, John Smith, he's got an allergy. You might want to rethink the medication that you're giving them. So they were positioning the trainee doctors, or they're describing the trainee doctors as perhaps being a bit naive or being a bit new. And also the second example there from Wallace talks about making subtle suggestions. So again, the nurses were very mindful of the fact that for trainee doctors, they often felt a very strong sense of jeopardy, particularly in ward round when they're the more senior consultant, and perhaps the senior consultant was asking them questions. So the nurse would very quietly make suggestions to the trainee doctor about things that they might want to do or that they ought to do in order to try and keep the patient safe. However, I do have to caveat that with saying that they'll do that as long as the patient was safe. But if they felt that there was a direct risk to patient safety, then the nurses would directly intervene. And then the third quote there is a bit more controversial and a bit more colorful, but it sort of echoes the sentiments, I think, that I referred to in the background, that sometimes there can be tension between trainee doctors and nurses. And in this particular example, Julia was talking about her role, because she's a consultant nurse in infection control. And she felt very much part of her role was to ensure that patients always sanitize their hands before approaching the patients. And she was saying that in this particular encounter, she had told some junior doctors to make sure that they disinfected their hands before approaching a patient. And one of the junior doctors has come back with a very negative response. And this was an interesting part of the study, which I won't have time necessarily to go into today, but it's quite interesting that these narratives, these more colorful narratives, seem to arise when the junior doctors were new and they didn't quite understand the role that nurses in that particular setting had to play. But that over time, the relationship changed and became a more productive and meaningful a more meaningful relationship as well. But I'll certainly come back to that last quote later on in my presentation, because I think it highlights the issues sometimes with regards to communication and engagement between doctors and nurses. And I felt that was very much around ethical capability. So the ability of trainee doctors, as described in this instance, to be able to understand the role and contribution that nurses play in terms of ensuring that patients are safe as well. In terms of providing emotional support, very much similar in some respects, I guess, to providing general support, but this was specifically about emotional support. And in these narratives, the nurses spoke about specifically challenging instances that perhaps trainee doctors may not have come across before. So in the first quotation there from Anne, she was talking about her encounter with a patient that had died. So the trainee doctor had tried their best to keep this patient safe and tried to keep them alive for as long as possible. Unfortunately, the treatment that they implemented had been unsuccessful, and the trainee doctor was really struggling to come to terms with the unexpected death of a patient. So she'd intervened to take the trainee doctor aside, and she'd taken him to a quiet room and made him a cup of tea. And she'd reiterated the sort of key points that I've highlighted there in bold to say, you're only human. It's only natural that if someone dies and you're looking after them, it's natural for you to grieve for that particular person. And again, this was interesting because very much the nurses were saying that they felt that if the emotional issues or emotional challenges that the trainee doctors were facing, specifically in relation to patient care, patient safety, they'd often turn to nurses because they felt that there was less of a sense of jeopardy, and they felt uncomfortable approaching more senior doctors because they felt that they might be looked down upon perhaps, or judged for not being as resilient as perhaps they ought to be, or they might want to be perceived as well. And also similar with the second example, where Brenda was talking about a patient who deteriorated very quickly and then unfortunately died as well, and the impact that had on the trainee doctor as well. So for those of you, I'm sure who've read Wide Literature on Patient Safety, it's the notion of second victim. So if someone has an adverse patient safety outcome, it also affects the people that are looking after them as well. And again, similarly with Brenda, she also describes here intervening to take the trainee doctor away from that particular setting, having almost a debrief away from that particular setting, and then reassuring him and providing the trainee doctor with the emotional support that they needed to be able to then progress as well. Okay. And then the last sort of broad identity that the nurses described as adopting, particularly with regards to patient safety, was working as a team player. So here they're talking about the fact that they tried to work as people that recognize the value and expertise of others, respected others' contribution, and worked with them in a collegiate way. And also they spoke about trainee doctors as willing to work, as very willing to work with them in a collegiate way as well. And interestingly, I mentioned before that although I present the identities here as 7 disparate identities, actually there's a bit of a process or a trajectory. So initially when the nurses encounter trainee doctors for the first time, there's a bit of tension in the relationship. But as they start to get to know each other and the nurses provide support for the trainee doctors in a different way, over time, nurses and doctors tend to get to this particular state where both the trainee doctors and nurses are working together as team players. And as Fionn says there in the first quotation, once the trainee doctors and nurses get to this state, then there's a mutual understanding of roles. There's a real depth of trust in the role and practice of a nurse, but this takes a little while to grow. And this takes a little time to grow. So this is a process that takes a little while to sort of grow and develop. In this instance, Fionn was talking about relationships that she had built up with 4 trainee doctors who were consultants at the time when I did the study. So she's talking about the fact that she'd built this relationship with them over time, from when they were trainee doctors up until the time that they became consultants. So over time, they'd built up this really good relationship of mutual trust, which then made it easier to maintain patient safety when they work together in clinical practice. And then the second point, I think, is another key point, which Anne made, which is from her experience, in terms of patient safety, the doctors tended to do better and function better with regards to keeping patients safe all the time, were those who were prepared to work in a collegiate way and also to engage with the views and opinions of nurses. And her advice to any trainee doctors was for them to utilize nurses and to engage with them, and not to see them as a disparate profession or to see them as a lesser, but actually to engage with them in a meaningful way, as they also had the same ethos of wanting to engage with them and with the patients to try and keep the patients safe as well. So broadly speaking, those were the sort of 7 main identities I think that that we found in this particular study. So in terms of conclusions and key messages, I think for me, one was the value of Cheetham and Shiver's model around the different domains of competence. So you'll have seen in the quotations that I've presented to you, nurses intervene to support doctors in a variety of different ways, particularly in relation to the 4 key domains there, which are at the heart of that module. So in terms of personal competence, functional competence, ethical competence, and cognitive competence. And in essence, for me, nurses are part of the solution rather than part of the problem. The other thing that I wanted to just highlight before I move on, I guess, is looking at the wider literature and looking at Lynn's study historically, there seems to be a notion or an implicit notion, which is somewhat hidden, or a sense that nurses are really good at providing trainee doctors with emotional support and are really good at providing them with general advice and guidance. But where the flashpoints tended to be in relation to patient safety, related to things specifically around functional competence and cognitive competence. And what I mean by that in plain English is essentially when the nurses were working with trainee doctors to ensure patient safety and they were being advisors or they were providing emotional support, there seemed to be less tension in those sort of interactions. The relationship seems to be less fraught. The tension points tended to come when the trainee doctor wanted to do something and the nurse said, no, you can't do that. This is how you should do it. That's where the tension seemed to arise. And that tended to relate to things that some trainee doctors may see as being the remit of medical doctors only, things like prescribing drugs or medication, assessing patients, ordering treatment or diagnostic tests. So those seem to be more those seem to be the cases where there's a bit more tension in the relationship. But eventually that was resolved over time as people got to know each other a little bit better. Interestingly enough, like I said, this is only the second study where it talks about the possibility or the existence of a mutually beneficial relationship for both nurses and trainee doctors, which is in sharp contrast to the vast majority of literature, which only talks about a negative relationship between trainee doctors and nurses. And also what this study echoes, I think, which aligns with previous literature, is that at the heart of all of this is communication. And for me, what this study is demonstrating, what I hope it adds, is it's not just communication in the day-to-day reality of patient care. It's also about understanding each other's roles and understanding the variety of different roles that different people can play. And I think in fairness to the trainee doctors, I have to acknowledge that this study only included nurses, so we didn't actually talk to trainee doctors, so we don't have their perspective on these interactions. The other thing which I think I ought to acknowledge as well is that for trainee doctors, it's really challenging to know what nurses can and can't do. So I've talked about the fact that we're different types of nurses. Nurses who worked on the ward, we had advanced nurse practitioners, we had nurse specialists, we had clinical nurse specialists, we also had consultant nurses. And one of the challenges, if you're working clinically, is lots of nurses can have the same title, but what they can actually do is very different. So an advanced nurse practitioner in accident and emergency may be able to prescribe, they may be able to diagnose, they may be able to order things like x-rays and to refer a patient or discharge a patient. But an advanced nurse practitioner who's working in cancer care may not be able to do those things. So therefore, if you're a trainee doctor, it's really hard to know what individual nurse can do because their job title is an accurate reflection of what they can actually do. So there's that added layer of complexity. So I think that also adds to the issues around communication, both for doctors and for nurses as well. And what I hope is that some of you in the audience, some of you watching this recording, first of all, are inspired to look at this issue in a bit more detail. So in this particular study, I looked at doctors and nurses specifically. I suspect that for all the other health and social care professions, they potentially are similar issues. And certainly, I think it would be nice to have some more research looking at some of the other disciplines. I'm thinking particularly about allied healthcare professions, occupational therapists, colleagues from pharmacy, radiographers, but also colleagues from social care. So I'd hope that we'll be able to do more research looking at the nature of the relationship, specifically with regards to patient safety. And then finally, I think my sort of take-home message is that nurses play a key role in ensuring that junior doctors consistently deliver safe, high-quality care to patients. The challenge, however, for both is that I think this work is somewhat invisible. So in terms of nurses and their workload, the work that nurses do to support trainee doctors isn't always visible. But also, as I said in relation to the previous slide, it's also challenging for trainee doctors when they're new to a particular setting to know exactly what it is that nurses can and can't do. And then just lastly, some references to conclude my talk. So thank you very much for listening. I'm open to discussion and debate, and I'd be keen to get your thoughts and feedback as well. So I'll just stop sharing if that's okay. Yeah, so Beth, give me the nod. So I shall stop sharing my screen now, if I can.
That's fantastic, Ray. Thank you ever so much for that. What a tremendous and novel piece of work that you've done on it, and quite complex as well in the combination of different types of analyses. So I wanted to open up to the attendees today for any questions that people might have. I wonder if you have any questions, you could raise your hand. So Lorelei, you're the first in there.
Hello, thank you very much. I just want to reiterate Beth's comment. That was just tremendous. And may I compliment you on your analysis. It was just such a brilliant analysis with all the different approaches. So my name's Lorelei, I'm from North Wales. And so I was very interested to see this.
Yes.
And I'm at University of Bangor in the School of Health Sciences there. And one of the things that occurred to me was the possible influence of what I think we call here sort of Ford Gymraeg, which is the Welsh way.
Yep.
And I mean, there's a particular way of doing things in Wales. It's a very small system. People all know each other. We all live close together. Certainly where I come from, we see each other in Saturday at Morrison's, etc. So, and the way things are done is very different to, I spent 20 years doing research in England, and I can see the differences in relationships and the way things are done in Wales. And I'm just wondering to what extent some of this might be a Welsh context.
I think that's a good point. So yeah, I spent many wonderful years in Wales, so I do get the point that you're making, and I do agree that there's a sort of contextual and cultural issue that exists as well. But what I found fascinating with some of the accounts that the nurses gave, they talked about trainee doctors, not just those who they'd worked with in the Welsh context, but also those whom that they worked with in England. So that there did seem to be some sort of crossover in terms of a lot of the issues that they encountered with trainee doctors. But yes, I think for some of the nurses, the sort of Welsh context and the organisation and delivery of healthcare within Wales was potentially a factor, but also I guess the other part of that is the way that medical doctors are rotated within Wales, because there's a particular approach to medical rotation as well. So I think that those certainly are factors that were at play. But I think some of the examples were also within the English context as well. So I think some of them would translate and be relevant to colleagues from England.
Thank you.
Diolch yn fawr, Lorelei, I have to say, into that question. So we have something in the chat here, which is from Gillian James. So Ray mentioned visibility right at the end. As a clinician, I definitely recognise these findings. Great study making the hidden work of nursing visible and the importance of professional relationships. I've not worked in Wales. I found the same in the large city hospital trust. So that's just reiterating the fact that this is generalisable to other areas of the UK as well. So are there any other questions for Ray? Just seeing if any hands are going up. Peter.
Hi, Ray.
Hi, Peter.
Nice to see you, and thank you very much for that presentation. Very clear, very structured, really good. Really enjoyed that. I was fascinated by the point around collective responsibility.
Yep.
And I think what you were saying, I may have zoned out at that point, but that there's perhaps a bit of a tension between collective responsibility and also individual responsibility, because of course, if we're collectively responsible in a team, then there could be an assumption that well, someone else will do that because I'm part of this team and we're collectively responsible. Whereas there's also that element of being individually responsible to make sure that you do your bit for the job. that needs to be done in terms of preserving patient safety, I suppose. But you also touched on the sort of idea of each member of the team, if you like, knowing what the others can or can't do. So advanced nurse practitioners and so on and so forth. And it just made me think that as a junior doctor going onto a ward for the first time, you probably would be thinking to yourselves that you need some help, you need to find your way around. And effectively, really, it's just a more experienced person working in that area, helping you to understand how to work in that area. But there's this sort of conflict with the fact that they are also a doctor, and therefore they may have certain responsibilities and things that they have to do. And I suppose it's that understanding that bit really, which is, for what things does the buck stop with me, and for what things does it stop with everybody else? And I was interested in that, whether that came out in, this kind of tension between those different things. Sorry, a long question.
No, good question. The good news is there actually is a quote that talks specifically about that. I didn't include in the presentation because of having a limited amount of time, but it's actually in the full paper where literally one of the participants took a doctor aside who was struggling with patient care, and he was saying, well, the buck stops with me because I'm the trainee doctor on call. And the nurse took him aside and said, no, it doesn't stop with you, it stops with the consultant. It only stops with you if you don't ask for help and if you don't ask for advice. But the sort of essence, if I've understood it correctly of your question, is right, that there is a tension here in that it strikes me that trainee doctors are socialized in a particular way before they come to clinical practice about what they're socialized to expect nurses can and can't do. So generally speaking, the impression that I got was a lot of the trainee doctors are socialized to believe that nurses are there to provide emotional support. They'll help you with the softer skills in terms of professional competence, things like communicating the death of a patient. What they're less aware of is that nurses can actually do a lot of what you can do. They can assess the patient, they can take bloods. In fact, they're probably more competent than you because they do it every single day. And that's where the tension tended to come in within the relationship, that the trainee doctor tries to do something, they're not doing it correctly. And like a wise parent, the nurse tries to whisper first of all, says, don't do that. If the person persists, then they become bolder. And then ultimately the nurse will intervene and say, no, you're not doing it. Step away from the patient. I'm bringing the consultant now, which is where a lot of the tension tended to come in. So yes, there is this sort of tension between how junior doctors are socialized and what they come to believe is their individual responsibility, but also what nurses see as being their individual responsibility and what they see as being their collective responsibility with regards to patient safety. And I think it's invisible in both senses. So the work that we've described here is not recognized as formally being part of the nursing workload. There's nowhere you'll find where it says part of nurses' role is to educate doctors or to train them. It doesn't exist. It's just done by nurses to try and keep the patient safe. But also from a medical point of view, there is no point, as far as I can tell, in terms of medical curricula, where they go through in this sort of detail what advanced nurses can do. They generally are interprofessional education sessions where you learn alongside other students. But these are nurses with extended roles who are functioning at a very high level. So some of them, for example, are nurse consultants who have their own caseloads, and those patients never actually come across a medic because the nurse sees them all the way through.
Yeah, that's, I guess what you were saying there is that there's a lot about assumptions about what people may or may not be able to do. So, and that can work both ways in terms of junior doctors assuming that nurses can't do certain things or can do certain things, and vice versa. I'm reminded of my son, who is a doctor, but who during COVID actually had to get a job being supporting phlebotomy in the hospital. So he went around and took so many blood samples. When he finally went onto the wards, he was actually really quite good at doing that sort of thing. But that, the assumption then would have been, oh, he's a junior doctor, he won't know how to do it. But in fact, he could. So I suppose it's about people talking to each other and working together in a team, isn't it? And understanding what their roles are. But anyway, thank you very much. I'll shut up.
Thank you very much, Peter, for that question. I think Hannah, you've got your hand up.
Thank you. And I just want to say again, thank you for such an interesting talk. That was so interesting. It's kind of building on the discussion that you've been having around this invisible work that isn't part of the nurse workload, and how much nurses see that this is part of their role and whether or not it can be burdensome, or if it can bring about any negatives or if they get any positives out of it. More information on that.
It's a really important point, and for me it was fascinating because, like I said, I spoke to nurses at different levels, and what sort of struck me was all of them acknowledged that just extra work, which wasn't formally recognized as part of their roles, but all of them felt it was important for them to do it anyway. And it was a part of the job that they valued because they saw it as being crucial to keep the patient safe. So their main focus was, I'll do whatever it takes to keep the patient safe. But also that if you want to think about safety in its broader sense, that also then encompassed keeping the trainee doctor safe. And it sort of related to the point that Peter was making, because even the consultant nurses recognized that the trainee doctors had a role to play that they as nurses couldn't play. So they also saw a key part of their role as being supporting the trainee doctor and keeping them safe. So the two examples I think that were in my results where the nurses took the trainee doctors aside, at that point they were concerned that the trainee doctor might then go off sick. Again, it's in the paper, but not in the presentation. When I talked about the longitudinal nature of the relationship, one of the nurses said a trainee doctor who was about to become a consultant at the time of the study came back to her 5 years later on a different rotation and said, well, I was struggling in year one as a trainee doctor. You took me aside, you gave me some kind words, and I've always remembered that. And that's what inspired me to stay in medicine. I might have gone off and done something else if you hadn't taken me aside. So nurses saw it as very rewarding, as a very rewarding part of their role in terms of supporting the patient, make sure that the patient was safe, but also supporting trainee doctors. And they took a great deal of pride when someone who they'd worked with as a trainee doctor, where there's a bit of tension in the relationship, that relationship evolving and blossoming, and that person becoming consultant and coming back as a consultant. And again, there's another quote that's in the paper where the nurse says, when I started off with him, I used to tell him what to do. Now that he's a consultant, he comes to me and he'll ask me questions, but he's just asking me in jest, but he still checks in with me. So nurses, it is quite a lot of work for nurses, and they did sort of point that out, which isn't formally recognized in any meaningful way, but they saw it as being vital to their role as custodians of patient safety, but also in terms of keeping everyone within the wider team safe and supported as well.
Brilliant, thank you, Ray, and thank you very much for that question, Hannah. I think we've possibly got time really for one more question before we begin to wrap up. So is there any additional questions from the group here? I can't see any hands going up, so I think well, ask something which I guess is quite obvious, but it'd be really interesting to hear your views on it, Ray. What do you think a message from this, from members of the public might be?
Oh, okay, that's a good question. I think the key message for any member of the public, I think, is being aware that nurses have a key part to play in terms of ensuring that patients are safe. So if you come across nurses intervening or communicating with doctors in a particular way, very often they're driven by the motivation to try and keep yourself and your loved one safe. Yeah, so my key message, I think, is that basically the main function of nurses, as they see it, is to keep you safe, to make sure that you receive the best possible care, regardless of who's looking after you, what the circumstances you're being looked after are like. And they'll often do their utmost and do their very best, and they'll often intervene directly if they think that things are not as they should be. So I think that probably would be my key message for the public. Thank you.
And I mean, I was really struck by your the blue text on your slides, and which were the with summary of the identities, weren't they? And I
Yes.
it just came across like a job description to me, and it when you put them all together, and I wondered how much you felt that these things should be more formally part of nurses' job descriptions, rather than like this almost a hidden and under-recognized professional roles that they play.
No, I think in terms of patient safety, it's important that it's formally recognized, because then it gives them, I guess, the rights to be able to intervene, and it hopefully would reduce the tension and pressure or the sort of differences that arise. But yeah, I certainly think it should be recognized as part of nurses' formal workload, and it should be included in every job description. I think for me, the first responsibility for every nurse is to keep the patient safe. That's what people should be determined to do. And even if that means sometimes upsetting people, as long as the patient's safe, I think that's the sort of most important thing. Equally, the other 6 roles are just as important. So it's important for you to support your colleagues, to work in a collegiate way, and to help people to navigate the system, because we've all been new. We've all had to work in a new place at some particular points in time. So I think all of those things are key. However, I suspect that the challenge is nurses are already expected to do so much. It's, I guess, what would make way in the role descriptors. But what my argument against that sort of narrative would be, I suppose, that those 7 identities really ought to be the guiding principles that underpin all that nurses are expected to do. So everything else should be subservient to those 7 identities or roles, because I think they're at the heart of what nurses should be, which is keeping the patient safe.
Well, I'm sure that we have nurses on the call here, and I'm sure they'd be delighted to discuss this in more detail with you. There's more comments thanking you in the chat there, Ray, and Lizzie, who's saying that it resonates with her experience as a trainee doctor. People asking for your paper, which I've posted a link to it in the chat, and then Angela has thanked you for saying the findings resonate with her experience as a nurse who often mentor new staff. So I'm sure everybody will thank me in a heartfelt, join me in a heartfelt thank you to Ray for the time and care you've put into preparing today's presentation. It's obviously created an awful lot of interest and given everybody lots to think about. So many, many thanks on behalf of the attendees today and of the Yorkshire Quality and Safety Research Group. Never miss an opportunity to plug your next session. So our next seminar is actually in person. So that is on Wednesday, the 21st of June, between 11 AM and 12 PM. And the seminar is done by Duncan Smith, who is a senior lecturer in advanced practice at City University of London and an honorary nurse consultant in critical care outreach at University College Hospital NHS Foundation Trust. And Duncan's seminar is going to be on developing a complex intervention for deteriorating patients using theoretical modelling. So as I said, that will be at the Wolfson. And if people don't know where that is, it's on the Bradford Royal Infirmary site near where Bradford Institute of Health Research is. It's the Wolfson Centre for Applied Health Research, and that's Wednesday the 21st of June between 11 and 12. And I think Hannah has put the Eventbrite link in there for people to sign up if they want to. So once again, thank you to everybody for attending today. It's much appreciated. And yeah, we hope to see you at future seminars and hopefully to the seminar in June.
Thank you very much.
Thank you again, Ray.